Guys all coming for our grand rounds. This is the March 2018 or February 2018 edition of grand rounds. So today we have Dr. Andrew Feher with us talking about adhesive capsulitis and diagnosis and treatment of it. He went to for his DPT. He went to Arcadia University. And he did an orthopedic residency at the best orthopedic residency in the country at St. Luke's University Health Network. No bias at all there. And he is now a fellow in training at Regis University in Colorado. So without further ado, Dr. Feher.
All right. Well, thank you for everyone for coming. So everything I know I learned from Steve. Okay. Steve, you hit the record, right? Okay, just making sure. So I practice out of the West End location in Allentown. So we do see a fair amount of shoulder conditions, and we do see some adhesive capsulitis coming through. So the main purpose of this talk is just to go through some of the current research on it, and then talk mostly about kind of how we manage it and just how we try to efficiently manage the course of it and just make sure that we're using all of our resources to the maximum just to get the best patient outcomes that we can. All right, so I have no disclaimers to make. The objectives, so we're going to start by just going through some of the etiology and the prevalence, just to get some background, kind of some risk factors of what we're looking for that may increase the likelihood of you putting adhesive capsulitis on your radar, some of the prevalence, and then we will move on to the clinical presentation. So if you're in an evaluation, kind of some of the hallmark signs that you're looking for, so that you can start to piece together the picture of it. And then finally, really the biggest thing that we're going to spend some time on is looking at patient management, because there are tons of options out there, and you'll kind of see when we go through. There's a lot of research on adhesive capsulitis, and there's a lot of things of if you go injection, you get surgery, you get PT, and it's all kind of mixed. So most of the presentation is going to spend on some of the treatments and kind of how we can mix and match to make sure that we're getting the best care that we can. So the big thing that you'll see going through with the research is it's very difficult. For adhesive capsulitis, it's very important to stage the patient correctly. They could be in acute phase, they could be more in a chronic phase, and that's really going to impact what kind of interventions you're going to provide. And you'll see going through with the research, they're not always exactly clear of where the patients were in the study. So it makes it hard to try to generalize it to all populations. So that's just a little bit of the grain of salt that we have to take with some of the research. So why this topic? So seeing it and kind of doing identification on it is more the easy part, because you'll kind of see someone come in, they're very restricted shoulder motions, extremely painful. If they're in the proper age range, it should be somewhat higher on your list. But then, like the management, it does get to be a little controversial because there are different studies saying if they do this, they'll have better outcomes. If they do this, they'll have better outcomes. So we'll just try to go through and just make some sense of it so we have a little bit better picture. Let's see. So just some of the etiology. There's two basic types of adhesive capsulitis. The first one is going to be the primary, which is more or less there's no known cause that they know for sure was the cause of it. It could be if they do have some diabetes or if they have some thyroid issues, that could certainly contribute, but there's no definitive cause that says that this led to adhesive capsulitis. The secondary causes are going to be something that we know. So if they had a trauma, if they had surgery, and those are things that we can kind of draw a line from. They got surgery and never really got their motion back, and then they ended up getting adhesive capsulitis. So it's more of a direct route, and it's a little bit easier for us to put our finger on exactly what caused it. So just looking at a little bit of a diagram, this just breaks down some of the causes. So again, you have those two main categories of the primary, and then you have the secondary. You can see the secondary are from something that we can draw lines to whether or not they had surgery, if they have arthritis, if they have an underlying rotator cuff tear, those things can always feed into the secondary, which we can draw a line from them. And the primary is kind of a throw. We can make some judgments and some guesses of what caused it, but really there's no direct relationship. But both they will usually present very similar. So it's not so important that we know exactly if it's primary or secondary, but it is good just to kind of know some background going in. So some background on shoulder pain. The overall prevalence is between 2.4% and 26% just for general shoulder pain. The primary adhesive capsulitis will account for a small number of that, and the secondary has a pretty broad range, which can include 4.3% to 38%, depending on what kind of study you're looking at. And unfortunately, it does occur bilaterally. In some cases, which can obviously be very debilitating for the patient, because now they have two shoulders that are pretty much out of commission, because you've probably seen some that have one and it's very difficult for them to function. So obviously if they're one of the unlucky ones that gets bilateral affected, it can certainly be quite the impact on their life. So some other risk factors that you may see. If they have a history of Dupuytren's contracture, that can certainly feed into it. The thought is that they have that adhesive nature and the inflammatory nature, which can obviously have an impact on other body regions and not just the hand. Females are more predisposed to having an episode of adhesive capsulitis, and the majority of the age range is going to be between 40 and 65. The main peak is from 51 to 55. And also one of the predictors, if they do have a history of adhesive capsulitis on the contralateral side, there is that chance that they will develop it in the other shoulder at some point. So just something to note in history, if you do know that they have a history of adhesive capsulitis on the contralateral side, they do have that chance of also developing it on the other side. So some other risk factors will be trauma. So obviously if they fall, if they have a fracture, if they have a muscle tear, if they have a soft tissue injury, you start that inflammation, that can certainly sit in there and then cause them some problems down the road. If they had surgery, or if they have to have their arm in a sling or a cast, that can certainly play into it. Autoimmune disease. Cardiac surgery was also known. That was kind of one that was a little bit new for me, but we have had a patient that did have an open heart surgery, and then he ended up developing adhesive capsulitis on the left side, I believe it was. I've looked at the studies. I'm not exactly sure what the cause of it is, but it has been known in literature. So there's still kind of looking into it, but just one of those things that you don't really think of that being an increased risk, but it does play into it. And then, like I mentioned, thyroid disease does play a role just because of the circulating hormones and some of the effects that it'll have on inflammation in the body. All right, so getting into a little bit of the clinical presentation. When you go through your subjective, they're usually going to report that they just kind of started having a gradual loss of motion. They can't point to an instant or some type of injury, but they'll just note that they just gradually started losing more and more motion. They will have a sleep disturbance, most likely, that they can't lay on it. Especially at night, the pain can get worse because they've gone through the day, and then some of the inflammatory markers will go up at night, and that will cause a little bit more pain and difficulty sleeping. And then usually they kind of give you a quick overview of how they reach, and it's not looking like they can get a whole lot of motion. You'll just kind of see just a global loss of motion. They're really not able to get much overhead or behind the back, and they'll usually say they have trouble pulling up their pants, or they're trying to don a bra or a shirt. They'll just notice that they're having a lot of issues with that. As far as the objective findings, it's always kind of been shown in the literature that you're going to lose the external rotation first, followed by abduction, followed by internal rotation. If you actually take a look at that in some of the studies, the objective measurements don't always follow that exactly. So that's not a hard stop, that if you don't have that loss in that pattern, that you can rule it out. More of the general guidelines now are as if they have an over 25% loss in at least 2 planes, if they have a 50% reduction in external rotation, or if they have less than 30 degrees, or a 30-degree difference. versus the contralateral side. And always kind of a key finding is that the external rotation in neutral is going to be more limited than the external rotation in abduction. That was always kind of something that was a little bit counterintuitive to me, but in a couple slides we'll go over a little bit more of the mechanism and kind of why that exists. This is from the clinical practice guidelines, just going through some of the characteristics that you may see, and we touched on a lot of them, but that middle age range from 40 to 65, it's usually just an insidious onset, or they may have a little bit of a shoulder tweak that they mentioned in their past, but nothing really that draws too much attention. They usually have a lot of night pain, difficulty sleeping. They're going to have a lot of difficulty trying to reach up actively behind the back. Usually looking for a 50% greater or 30-degree loss of passive external rotation. All end ranges are usually painful, and then I usually find that they're going to have some weakness, especially in the internal rotators. And the next slide kind of points to why you're going to lose that motion both in neutral, also have that weakness in internal rotation. So if you look at the rotator interval, this is one component of the shoulder that's usually affected and implicated in adhesive capsulitis. So on the top, you're going to have the supraspinatus tendon. On the bottom, you're going to have the subscap, and then it kind of joins with the middle glenohumeral ligament. So if you start having an adhesive process, and now the tendons and the capsule and the ligaments are all becoming more bound down and inflamed, that subscap will now not have the ability to translate when you're trying to rotate their arm outward. That's going to be more pronounced when the arm is down because of just the pulley of the subscap. That's also going to account for some of the weakness that you're going to see. Because if they try to go to contract that subscap, the tendon is not going to want to be able to contract as efficiently, so then you're going to have a lot of weakness. Again, it's kind of tough to tell if they're having significant pain in the shoulder. I'm sure there's a little bit of just like a general pain inhibition going on, but they're really not able to recruit that muscle because of the painful stimulus. Looking at the staging for adhesive capsulitis, the first stage is really going to be the pre-freezing stage, and we generally don't see patients in this stage because it is fairly quick, and usually by the time they get to see any of us, it's really going to be in the further stages. But the pre-freezing stages are going to have some deltoid pain at night. If you are able to do passive motion on them, you're going to get more of an empty end feel from pain, and there's no true range of motion loss. So if they were under anesthesia, you would be able to move their shoulder normally. If you looked at the capsule, there's not going to be any adhesions in the capsule at this point. Then they'll move into the freezing stage. They still have that pain at night, but if you do examine the shoulder and the capsule under anesthesia, you will see that there is now a motion loss and there's actually some adhesions forming. In the frozen stage, stiffness is going to become much more dominant at this point. They're going to have pain really only at the end range. So that acute pain phase is now kind of subsiding, but now more of the adhesions and the capsular restrictions are now going to set in. And then finally, you're going to have the thawing phase, and this is really where the stiffness kind of starts to relax and they start to walk themselves back to where they were. The pain is really minimal at this point. They just really have a stiff shoulder just in general. This was from a study. They actually looked at and they took some samples of the tissue. So you'll see in the pre-freezing phase, they do have the inflammatory cells. They're actually going to have an increase in the vasculature as well, and that certainly accounts for some of the pain and the inflammation. They're going to have the synovitis that is present, and then, like I said, if you do look at the capsule, you're not going to have any actual restriction. There's no tissue changes. It all looks the same, just very inflamed and irritated. If you move on to the freezing phase, they're still going to have that synovitis. They're still going to have the increase in the vasculature, and now you start to get the scar formation. So some of the tissue is now starting to look a little bit different. It's a little bit more of a collagenous viewpoint, and it's more of an adhesive tissue than it was in the previous phase. And then finally, in the frozen phase, there's not as much of the synovitis left. And now the cell structure is really starting to look like fibrotic tissue. That's what makes it so hard to get the motion back, because now they've really changed that tissue and it's no longer like it was prior. All right, so this is really kind of the tough part of adhesive capsulitis, is you see how long this can go out, because you go from 0 months to 2 years really can take it to go through some of the phases. And I think that's really kind of one of the challenges that we face when we talk to patients about this, because usually we're used to seeing someone with back pain and usually a couple of visits and they're doing pretty well. But when you have to have a conversation with someone about the clinical course and you tell them they can go up to 2 years, it's a little bit demoralizing for them, and it's tough to kind of get them to buy into trying to do some rehab towards something that may take a very long time. So this graph is something that's a challenge, but I think if we manage it and you kind of handle the education piece well, it doesn't have to be such a negative impact on our care. So and I think really the big piece is we're able to get them to set their expectations at a realistic level. If they expect it to get better in a month or two, it's really not going to happen. So as long as you're able to you kind of set those expectations earlier in treatment, your success will be much better throughout the course of care. All right. So now the big part is kind of how do we manage these patients. We have an idea of the background, kind of what options are out there, but now we need to look at how we're actually going to manage these patients in the clinical setting. So do we do mobilizations? Do we do a referral? They can get a manipulation, go through modalities for some pain relief, stretching, surgical intervention, or should we just give them a home stretching device and have them do it on their own? So a lot of these interventions have been studied, and they do have some positive outcomes, but it's very hard to tell which one is best for my patient. That's what we're going to spend the next little bit of time going through, just making sure that we go through all the possible options and then when each of them is mostly indicated. All right, so the first one will be corticosteroid injections. They have been shown to be effective for pain relief and to dampen the inflammatory response. There's probably the strongest evidence for these actually for pain relief in pretty much anything that we're going to examine today. But the only kind of catch is that they are more in the short term. So one of the things that they do find, and we'll go through some of the research, but they'll find that the injections are usually more beneficial in the first 0 to 6 weeks. Then if you look at the long-term outcomes, if you compare an injection to PT or home stretching, they usually start to level out toward the end of the course. I don't think that's necessarily something to say that they're not worth it because you end up in the same spot. But I think we should probably take advantage of the pain relief that they can offer. These patients are having a hard time with their daily activity. So if we can give them 6 weeks of pain control, I think that's worth it, even in the long term, if they're really not going to get that much better by getting the injection. I think the pain control and the instant kind of boost in function is worth it. So the first study that we'll look at is from 2003, where they had 93 patients. They looked at a steroid injection. They did injection plus PT, just a saline injection, and just with PT, and then just a saline only with no PT attached. They found at 6 weeks the scores like in the outcome measures that were better with the steroid injection with or without PT. So just the fact that they had the steroid injection was the factor that got the scores to be higher. At 6 months, they kind of started to get a little bit closer as far as outcome measures, but the range of motion was a little bit better in the injection group at this point. And if you look at 12 months, they're actually having no differences as far as shoulder function or motion. So you can see by the end of the year, everything kind of leveled out, but in the initial phases, the patient did have better outcomes and better pain control in the early phases. The one note for the saline injection, that was kind of thought of as a control, but there have been some studies that just look at a saline injection just to get the capsule to expand. Their thought is that if you're not letting it to contract, if you do a little bit of it, a distension of the capsule actually helps. So it's not a true control, but you can see that the steroid injection was more beneficial than just the pure saline. The other study is 2005, there were 80 patients, and they looked at the injection. Same setup as the previous one. They did injection with PT, saline with PT, and then saline alone. They found that the injection improved the shoulder outcome measures much more than just PT alone or with saline. But they did find that if they did have PT with the injection, that their range of motion gains were actually better at that point, especially in external rotation. So this is something I think is a factor of if you're able to control the pain and they're able to tolerate a little bit more therapy, that probably accounts for the increase in motion. That's why they gained a little bit more compared to just the injection by itself. And the last one that we'll look at for injections is from 2016. It was a trial comparing injection with physical therapy with just oral anti-inflammatories with physical therapy. The injection was superior compared to the oral, and if you look at 12 weeks, there was no difference then at that point. So again, the injection in the short term really favors, but then in the long term, everything tends to even out at that point. So one note about PT in this case, they just did it in 3 phases. It was mostly just passive range of motion, pendulums, active range of motion, and then they did some strengthening. There was no note of doing any mobilizations or anything other than just some very simple exercises. So I'm not sure if it's a true test of what we do in the clinic, but that was kind of their format for PT. All right. So for mobilization, that's the basis of what a lot of things we do on the shoulder is to try to get some more motion through mobilizations. There is studies supporting, but really there's no talk on the direction or the intensity to see if a certain direction is better or a certain intensity or frequency is better than others. So the first one I'll look at is from 2006, where they look at high-grade versus low-grade mobilizations. They didn't do any exercise or home program. They just did the things in the clinic. They were seen 2 times a week for 6 weeks, and they found that there was a slight outcome advantage of the high-grade mobilizations versus the low-grade. But if you look at the ultimate results, there was a very small change between the two. The one issue with this study is they really didn't classify the patient as whether or not they were high irritability or they're more in the acute phase. So I think you have to take it with a grain of salt. We can't use the high-grade mobilization on everyone. You can't just take this that you have to do high-grade on everyone, because that can certainly flare up the irritability level, and then you'll actually end up going backward and getting poorer outcomes than you would like. I think the real takeaway from this study is that you can still get positive outcomes with doing low-grade. So that shows that depending on where your patient is actually falling, you do have the option to use either one, and they both can be effective. You don't have to do the high grade. From 2006, they were looking at to see if you're doing an anterior mobilization or a posterior mobilization, which one was going to improve the external rotation more. Generally, I think it's usually taught in school if you're going for external rotation, you're going to work on the anterior capsule. But they actually looked at it and they found that the posterior mobilization of the posterior capsule was actually more effective in achieving the external rotation range. Their kind of thought was that if you're restricting the posterior capsule, that's going to change the kinematics of the glenohumeral joint, and you're actually going to have improper gliding and sliding of the joint, which causes more tension to be taken up in the anterior capsule, and then you lose that external rotation. So they found that posterior mobilizations were more effective. They actually they did not do like the general pulse mobilizations that we generally do in the clinic, but they actually picked one. They did the glide and they held it for a minute. And then they would hold each rep for a minute, trying to total 15 minutes total for the session of the time that they were holding. So you can see on the left, it was the 2 anterior techniques. On the right, it was the 2 posterior. So I think it's just another kind of tool that we can use, because we don't have to do the oscillations. If you find a patient that just cannot tolerate the oscillations, even if it's a low grade, just doing a sustained hold may be good enough, you can still get effective results. So I think it's a good piece just to keep in mind in case you do have that patient that can't tolerate the oscillatory movements. The final one is going to be the study we looked at. There's 110 patients. They wanted to check to see what frequency is best for adhesive capsulitis. Are you going to do 2 times a week? Are you going to do 1 time a week? Are you going to do less than 1? They actually went with 1 to 2 times a month of doing glenohumeral mobilizations. They actually found that there was no difference in the total emotion gain between any of the groups, but the thing that they did find was that if the patient was more compliant with doing their home exercise program daily, it's like they were the ones that got the best improvement in motions, and they took the longest time to reach a plateau. So I think this really points to back to that education piece. If you tell someone that it may take a year or 2 for their shoulder to get better, it's going to be hard to get them to buy into doing a home program. But I think the home program is certainly a key piece of this, and if we're missing it, their outcomes are certainly not going to be as good as we would like. So I think it's a good little point just to point out to patients when you're doing your education. So stretching devices is another option that they are out there, and it is something that patients can get for home if they feel like they're going to have a better chance of stretching with these. If you look at the study, there are multiple ones that look at for shoulder, for elbow, for knee. If they do this low load, long duration stretch, it has been shown to be effective in improving motion and reducing pain. You can either go through this with using a device, like the one that was shown in the previous slide, and we'll look at one in the future as well. Or you can also set them up to do a positional stretch at home. If you're able to prop up some pillows or put them in some different directions, they still get that mild stretch. And I have some examples of those in the future as well. And if you look at the studies, the time that they recommend is pretty variable between 10 and 60 minutes a day. And that's something that is somewhat hard to sell to patients, because I know sometimes I have trouble getting them to do 2 exercises for 5 minutes. So if you tell them they have to stretch for an hour a day, that tends to be a little bit of a tall hill to climb with them. So that is a little bit of a challenge. But the one key, if you are using these devices or you're doing a stretch at home, you have to stay well below the pain threshold. You don't want to push these patients up and past their pain threshold, because you can set off that inflammatory response, and then we actually end up doing more harm than good at that point. This is a table just showing some different ones. It's for the shoulder, the elbow, and the knee. They were just looking at some of the effectiveness of using these devices. If you look at the box, one common theme is that they're all doing this below the pain threshold. I think that's a real key, no matter what you're actually using the device on, because if it's too painful, they're not going to keep it on for the amount of time that's required to truly notice the benefits. So it is very important to make sure that you're staying below that threshold, just to allow them to actually use the device the way it was meant. This is just an example of one shoulder device that you can use for external rotation. If you actually go on the website of the device, they're actually recommending that you do 3 30-minute sessions a day, which obviously an hour and a half a day is very tough, and most people's schedules probably don't allow that. So you also have to take that into account. If you feel that a patient may be appropriate, you do have to put that in, that it's going to take a fair amount of time to be effective. So you just have to clear that with the patient prior to see if it's even an option. Positional stretching is another option. If we don't have the devices, if the patient doesn't have the insurance benefits, we can get a little bit creative of how we set their shoulder up to still get a sustained stretch. I thought this little table was kind of interesting just to think about the way that we can position the shoulder to really target different parts of the capsule and different parts of just the glenohumeral joint in general. Some of the examples in the study were using the external rotation, both at neutral, 30 degrees abduction, 45 degrees abduction, just to get some varying positions, varying stresses to different parts of the capsule, just to really maximize their benefit. Because I think if they're really restricted in multiple parts of the capsule, if we're just focusing on one direction, we're probably missing a big part of the picture. So just to make sure that we're really kind of varying our stresses and making sure that we're going through and really getting all the areas that we need to. So modalities do have their place in this condition, because if they're not able to tolerate the injection or they're not willing to take the medications, the modalities are something that we can use. It's something that's fairly easy to obtain for patients, and I think it is a good avenue to bring down some of the pain if that is something that we feel we need to increase the tolerance to the exercise program or the therapy. So it is something that we can keep in mind. There have been some studies looking at if you do a deep heat or a more superficial heat prior to stretching. So they have found some usefulness in this population. But the main key is that it's really, there's no benefit if you're just using the modality. So if they're just coming in getting TENS or getting heat without any home program or some type of a stretching regimen, there's really no added benefit to just using modalities on their own. There's no great picture for patient education. This is the best one I found, but he looked like he got some good advice. So, kind of like I said, education is a huge part of this. Because of the clinical course, it is a little bit of a challenging course just with the timeline. So I think we oftentimes overlook education as part of our intervention, but I think it is a skilled part of our care that we should spend time on, and we should certainly consider that skilled therapy, because I think a lot of times they get a quick diagnosis from the physician, or they Google things online. And I think if we can spend more time with them, give them some realistic expectations, and kind of really set up the course of care, I think it does help, and it is something that is much more skilled than we often think it is. There was a study that just looked at patient education. They did one group that was just education on the natural course. They just talked to them about some activity modification to stay away from some aggravating factors, and just doing some pain-free stretching on their own. The other group was actually an aggressive PT group, and they found the constant score is a shoulder score that actually takes a little bit of the functional, but then also the objective. So they'll take motion, strength, but they'll also take some of their functional capacity, and they come up with a composite score. They found that score was actually better just in the education group. So even though they weren't getting any mobilizations, just the education of kind of the natural course and some self-stretching was more beneficial than doing a more aggressive PT. The one note, they did put in a study that they were doing the mobilizations, their quote was at or above pain threshold, which seems a little bit counterintuitive because it goes against most of the things that we see in other literature. So it's not a true comparison, because I think they were kind of doing more harm in that case. But I think the main point is just showing that they can get better just with education. Even if the comparison wasn't the best for PT, I think just the educational group is kind of reason enough to at least put more stake in education that we give. All right, so strengthening is something that's a little bit controversial in this population, because I think that the thought is if we're doing true strengthening, they're really going to flare them up. You're going to increase the inflammation, and you're going to set them back. There was a study in 2017. They looked at just using TENS plus mobilization, TENS mobilization plus strength. They want to see if the addition of strengthening either helped outcomes, if it hurt outcomes. And they saw that both groups actually pain, function, and mobility got better in all groups. But across the board, the addition of the strengthening it actually enhanced the outcomes. The strengthening that they actually talked about, I think strength is probably not the best word for it. I think it was more of a neuromuscular re-education. They weren't obviously loading these patients up with heavy weights, but they were using more of just tactile cues, some light therabands, really focusing on scapular activation. So I think the strengthening is a little bit misleading, but I think it just shows that we can incorporate some of this neuromuscular re-education, because if we are improving mobility, I think if we're able to get the active and muscle contraction, that's also going to help to you kind of reset the nervous system and bring down the pain, but then also improve function. So strengthening or neuromuscular re-education can be used. You just have to be a little bit careful with the intensity, the duration, and just be mindful of like the pain. The one exercise that they did using the group was called a shoulder sling. The band's around the neck and it goes around the elbow. The cueing is more of a press down the elbow and a retraction backward. So this is one of the exercises you can kind of see. It's more of a neuromuscular reeducation. You're not going to build a lot of strength with this. But I think it is important to somewhat include some of these in the treatment plan just so we're not missing a big component. But again, that same key stays the same, stay below the pain threshold. Because if we're doing that, you're pretty safe to move forward. Medical management is the other aspect of this. They can go under manipulation. There have been studies on capsule release. Both methods have been shown to improve mobility. There's not much evidence to suggest one versus the other. My own views is, I think the capsule release is a little bit of a risky slope, because if you do introduce that injury to the body again, you certainly can have some more scarring, some more inflammation. But in 2013, they did a study looking at 1,000 patients. There was a very slight advantage in abduction and external motion for capsule release. Some of the risks that have been known for the manipulation on the contrary side, there have been fractures, there have been nerve injuries, rotator cuff tears, labral tears. Those risks are getting much smaller because they are focusing more on a smaller lever arm. In the past, they were using longer lever arms, and that was found to have some more complications. They certainly are using shorter lever arms to try to reduce those complications. This is just a graph showing, you see both groups did improve. There wasn't much of a difference, but there was that little bit of an advantage for the capsule release for external rotation and abduction range of motion. One study that I did come across recently, it was done on patients in the Air Force, and it was actually PTs that were doing the manipulation. They didn't use any general anesthesia, but rather they just did a scaling block on that side. And they were actually using a translational manipulation. So similar to the mobilizations that we do in the clinic, just at a higher grade, and they didn't obviously have to worry about the pain response. So they were able to do translational manipulations in varying directions, and their outcomes were actually just as good as the full manipulation. And they had a significant improvement in really all directions. So it just shows that it doesn't have to be a long lever. And I just thought it was pretty interesting that there are places that are doing translational manipulations and using PTs. So obviously it's in the military. They have more of a flexibility to try those things. So I'm not sure if anywhere in common population is doing it, but I haven't seen it so far. But I thought it was interesting. So how do you really decide which way to go? There's a lot of different options, and most options are going to do something positive for the patient. So we really have to decide kind of how we're going to put this all together. So you really have to fall back on the Irritability Classification. This was from the Clinical Practice Guidelines as well, and it gives a pretty clear-cut set of characteristics that you can use when you're doing an evaluation. And what you're looking for is you're trying to place the patient in different categories based off the findings that are listed. You're going to classify the patient based off of where most of the characteristics are falling. So if they have 3 in high and 2 in moderate, you're going to then classify them in the high category of pain. This is helpful because I think it is something that is fairly easy to classify. There's not a whole lot of gray area between the two. There was a pilot study that was done a few years ago that actually showed that there is a good correlation between inter-rater agreement. I was actually part of the data collection on this study, and it takes only 5 minutes if you're the second person coming in to quick check pain, check motion. You should be able to place in one of these categories with just a very quick screen. And there was very high level of agreement in like the low 90%. So it's something that is fairly easy to use. It's also reliable. And I think that's a good kind of groundwork to build, because then we're all on the same page of how we're going to manage these patients. So if you go from the Irritability Classification, then you can move into, that was just the table from the study showing that the actual the reliability between the raters is very high at 92.3%. They also did an assessment just showing if you look at the top of photo, there is a severity scale, and that actually agreed with it 91% of the time. So that's a good thing just to take a quick glance at. If you're not able to do the full rating scale, you can at least take a look at the top of photo, and it gives you a good idea. The Star Shoulder study was looking at taking the irritability and then trying to match the interventions. So really, if they're in the high irritability, you're listening just to minimize the stress, trying to do some activity modifications, and just monitor their impairments at this time. You're not going to be able to improve motion a whole lot. Really now it's just more about monitoring where they are and just trying to minimize the effect. So at moderate stage, we start to implement some mild to moderate stress. We're just trying to get them back to more of a basic level of functioning. If they're in the low, that's when you can start to really go after the impairments. If they have some capsule restrictions, you can probably have a little better chance to actually do some more aggressive mobilizations or stretching to get them back to some of those higher level activities. So really the bottom line, the natural clinical course is very extended, as you saw from the graph. The pain and inflammation is a major limiting factor, so it's something that should really guide our treatment. You really want to be cognizant of pain and just make sure that you're really incorporating this in the treatment. Corticosteroid injections are very effective. They're more so effective in the short term, but I think it is something, like I said, that it does have some benefit, even if the outcomes are kind of leveling out at the end. I think that short-term pain relief is something that we should probably take advantage of if we can. The mobilizations should really be based off of irritability. You are able to do them, but just make sure that you're not pushing through that pain threshold, because you don't want to do more harm. Patient education is crucial. That's really something that I think we overlook, but I think if we do a good job education, that is something that can really set up success, because now the patient does not have these unrealistic expectations of how quickly they'll recover. The home exercise program is certainly essential for outcomes, and I think that is a big piece of the education that we provide, because obviously if we're seeing them in the clinic a couple times a month, that short amount of time is just not enough to really change the physical impairment. So you really have to drive home the fact that the home exercise program is something that should certainly be taken seriously. So really, it's just a balancing act. Just make sure that you're taking into account pain. You don't want to go too far and set off the pain again. But if we're able to kind of balance through some of the pain, and you just really make sure that we're monitoring impairments and just not flaring them up, we should have success and just use all the tools that we have available. All right. I hope nobody looks like the picture on the left here yet with their head down, looking like she's tired. But does anybody have any questions at this point? Yeah.
Do you expect to get full range of motion after 24 months?
Normally. So most of the studies are saying you do get full motion. Some of the ones were suggesting that it's more full function, not quite full motion. They're saying sure they can do their daily activity. They probably don't notice a whole lot. But if you would actually go in and take some measurements, you may notice a little bit of a deficit yet. But I think probably more importantly, people are able to function. They don't really notice it. So I wouldn't say that you get absolute full motion back, but you should expect full function at least. That should be for certain. Yeah, Nicole.
I may have missed it, but with the manipulations, is the long-term outcome the same whether they're manipulated, like under anesthesia, early? Does it make a difference?
For early versus late, or?
Well, even doing the manipulation, like it's a natural course of 24 months. Like
Yeah.
A lot of the things like steroid, at 12 months didn't matter.
Right.
What about the manipulation under anesthesia?
The outcomes are the same.
Okay.
I think it's just a little bit of speeding it along.
Little boost for the
You go from not having much motion, then they're able to move it fully under anesthesia. So you do kind of speed it up, but then obviously have to deal with pain then when they come out of the manipulation, because you kind of set that back and you're back into the high irritability normally. That is what I've seen. But yeah, long-term outcomes overall are the same. There's not a benefit of getting manipulation. It just jumps a few steps, I would say. Yeah.
May have missed this, but did you see any other literature on home stretching devices versus PT alone? Or?
No. So there are no comparisons. That's one of the challenges of the research too, because they take so many different comparisons, PT to injection, injection with PT compared to. I did not see anything just comparing a home stretching device versus PT. It was just more in conjunction with or just by itself, not in comparison to getting formal PT as well.
Andrew,
Yeah.
when do you like to do the patient education component about, hey, this may take up to 2 years, when a lot of the times we get a script that says frozen shoulder.
Yeah.
It's not truly a frozen shoulder.
Right.
It's capsular head mobility.
Yeah.
So when do you try to give it 4 to 6 visits to see how they do, and then see that they're not doing well and say, hey, this is what may actually be going on, or versus scaring people off in the first visit?
That's a good question. I think if I get a pretty clear picture of the first visit, and I'm like, it's certainly looking more like adhesive capsulitis, well, I'll do it the first day. Because I think, from what I've seen, if it's just capsular mobility restrictions, they're going to present just differently in my mind. Because I don't think you see the high pain levels that you normally see. I think you'll see more minor physical impairments versus a true adhesive capsulitis. So normally I'll do it the first day if I feel pretty confident. I mean, if you have any questions, you can certainly take some time to see if that shakes out over a few visits. But I normally do it the first day if I feel pretty confident in it.
You're focusing more like on the irritability scale then, and making sure that that's something that you're looking at. It's
Yeah, certainly based off the irritability scale, but just more off the physical exam. I think you'll kind of get an idea. I mean, if it's just some capsular mobility that you're noticing, but you're not seeing the pain levels, I think you kind of have to weigh that. If there's any question in your mind, I think I would definitely probably wait a little bit before jumping the gun and obviously telling a patient that's going to take 2 years when it could just take 6 weeks. I think that's a big jump, but you don't want to make, obviously. There's no reason to falsely scare the patient into thinking that they have something that's going to take 2 years. But normally, if it looks pattern-wise, I will do it the first day.
One of the questions that I frequently receive from surgeons especially is that based upon some of the studies, it takes 2 years.
Yeah.
Kind of going off of what Nicole said. It takes 2 years, so why should we send to physical therapy? Because it's not going to change the course of care. Do you agree or disagree based upon the literature that you've read?
So I don't agree with that. I think a big part is they're missing kind of some of the support and the guidance that you'll get throughout the process. I don't think it's really fair to just tell someone it's going to take 2 years and then good luck. I think that we provide the education, a little bit of supportive piece, gives the patient a little bit better idea of the outcomes. And I think if we're not at least arming them with the home exercise program, I think that they're pretty much just left out to dry. So I think just the addition, I think it's certainly beneficial to at least give them some support through the process. And I think if they're doing stretching, they can certainly take that time down. I mean, even if it's 2-3 months, I think that most people would argue that they would rather get more motion back in 2-3 months versus waiting the full 2 years. So I think that the benefit, it's not huge, but I think it's certainly beneficial still. Yeah.
Andrew, with your literature search, have you come across any studies about the use of regional interdependence?
Yeah.
I mean, with highly irritable patients, directing your treatment with thoracic spine, I find pretty effective.
Yeah.
But Is there anything out there?
Yeah, there is. So I kind of kept it more now just because I didn't want to go too far out. But there are certainly a lot for thoracic manipulation just to get that pain response. If you're looking at the cervical spine, obviously if they're trying to move a shoulder that's stiff, they're going to start to compensate all over the place. So there is a lot of research out there on the regional. It is a good point that I kept it out of the scope of this, but it is something that is beneficial because, yeah, a lot of times you just can't work on that joint because it's so irritable, but it's definitely something. Especially the one was looking at that, plus dry needling. It was out in Colorado, but they just did dry needling and just the subscap and some of the trigger points with some thoracic manipulation and cervical spine work, and the pain actually came down a lot without even moving the shoulder a whole lot. So that is something just to keep in mind.
I think that would
Yeah.
piggyback Steve's question.
Yeah. Yeah, just leaving them go. They're not going to get that treatment if they just go home. So, yeah. Definitely. No question on that.
Are there any questions on that?
No.
Okay.
I don't think
What
so.
other questions you guys have? All right.
Thank you.
Make sure if you're from New Jersey that you sign out, and please pick up a certificate.
Check those out.